Hi, this is Dr. Dawn Shepard. Today we're going to approach feeding and eating disorders not just from a diagnostic standpoint, but through a systemic, clinical lens. These are not simply disorders of food or weight. They are complex psychiatric conditions shaped by biological vulnerability, psychological processes, family systems, and broader cultural influences. As a nurse practitioner, it's critical to recognize that eating disorders carry the highest mortality rate of any psychiatric disorder, driven by both medical complications and suicide risk, making early identification and intervention essential. We also need to move away from outdated thinking that blamed families. Instead, we now understand that families are often central to both assessment and recovery and should be actively included in care. Our job is not just to recognize an eating disorder, but to know what to do next, when to treat, and when to escalate care. In this lecture, you will learn to identify the 6 DSM-5-TR feeding and eating disorders, recognize the relational, cultural, and systemic factors that influence their development, apply a comprehensive assessment framework, select evidence-based family-centered interventions, and navigate the ethical and legal challenges involved in treating these complex conditions. Eating disorders are a major public health issue, affecting about 28.8 million Americans over their lifetime, or roughly 9% of the U.S. population. They are also highly lethal, contributing to more than 10,000 deaths each year, about one death every 52 minutes, and carry an annual economic cost of approximately $64.7 billion. Prevalence has risen dramatically, increasing by 129% between 2000 and 2018, and presentations increased even further during the COVID-19 pandemic, particularly among adolescents and young adults. For nurse practitioner practice, this means eating disorders must be treated as urgent, high-risk conditions requiring early identification and intervention. Social media also plays a significant role, especially image-focused platforms that are associated with higher rates of body dissatisfaction and disordered eating behaviors. So screening should be part of routine assessment. At the same time, telehealth has expanded access to care and has shown positive outcomes in eating disorder treatment, including both live video visits and asynchronous models. The bottom line is that these disorders are common, costly, dangerous, and increasingly visible in everyday practice, which makes screening and timely treatment essential. Now let's shift into the DSM-5-TR feeding and eating disorders, focusing on the 6 diagnostic categories, their criteria, and how they present clinically in practice. The DSM-5-TR identifies 6 feeding and eating disorders, each with distinct diagnostic criteria, ICD-10 codes, and clinical implications. Starting with PICSA, coded as F50.89 in adults and F98.3 in children, this involves persistent eating of non-nutritive substances like dirt, ice, or paint for at least 1 month, and it must not be developmentally appropriate or culturally sanctioned. Rumination disorder, F98.21, involves repeated regurgitation and rechewing of food, not due to a medical condition, and is often self-soothing in nature. Avoidant restrictive food intake disorder, F50.82, is a restrictive eating disorder without body image disturbance. Patients avoid food due to sensory issues, lack of interest, or fear of consequences like choking, and in severe cases may require enteral feeding. Moving into the more classic eating disorders, anorexia nervosa, coded F50.01 for restricting type and F50.02 for binge eating purging type, is defined by restriction leading to significantly low body weight, intense fear of gaining weight, and distorted body image with severity classified by BMI. Bulimia nervosa, F50.2, involves recurrent binge eating with compensatory behaviors like vomiting, laxatives, or excessive exercise, occurring at least once per week for 3 months, with severity based on frequency of these behaviors. Finally, binge eating disorder, F50.81, includes recurrent binge episodes without compensatory behaviors, also at least once per week for 3 months, and is associated with marked distress and higher rates of comorbid mood and anxiety disorders. Clinically, the key is not just recognizing the behavior, but understanding the presence or absence of body image disturbance, compensatory behaviors, and medical risk, because those distinctions drive both diagnosis and treatment planning. Next, we will go through each disorder one at a time. Anorexia nervosa is defined by 3 core criteria: restriction leading to significantly low body weight, intense fear of gaining weight or behaviors that prevent weight gain, and a disturbance in body image or lack of insight into the severity of low weight. There are 2 clinically important subtypes. The restricting type involves dieting, fasting, or excessive exercise without binging or purging, and is often associated with rigidity, control, and perfectionism. The binge-eating purging type includes recurrent binging or purging behaviors such as vomiting, laxative, or diuretic use, and is associated with higher impulsivity, greater psychiatric comorbidity, and increased risk for substance misuse. Severity is classified by BMI, mild at 17 or above, moderate 16 to 16.99, severe 15 to 15.99, and extreme below 15, but clinically you must also assess medical instability and functional impairment, not just the number. There are several critical clinical flags you must always assess: suicidal ideation at every encounter due to high mortality risk, obsessive-compulsive features like food rituals or recipe hoarding, and medication misuse for weight control. Depression is common but may be secondary to malnutrition, so reassessment after nutritional stabilization is essential. Onset is typically in adolescence, and patients often lack insight, meaning family input and objective data are essential for safe and accurate clinical decision-making. Bulimia nervosa and binge eating disorder both involve recurrent binge eating, but the key distinction is the presence or absence of compensatory behaviors. In bulimia nervosa, patients engage in binge eating followed by behaviors such as self-induced vomiting, laxative or diuretic misuse, fasting, or excessive exercise, occurring at least once per week for 3 months. These patients are typically normal weight or overweight, not underweight, and their self-esteem is strongly tied to body shape and weight. Severity is based on the number of compensatory behaviors per week, and medically, these patients are at high risk for electrolyte imbalances, cardiac arrhythmias, and gastrointestinal damage, as well as increased risk of suicide. In contrast, binge eating disorder involves recurrent binge episodes without compensatory behaviors, also at least once per week for 3 months, and must include marked distress. Diagnosis requires at least 3 associated features, such as eating rapidly, eating past fullness, eating when not hungry, eating alone due to embarrassment or feeling guilt or disgust afterward. These patients may be normal weight, overweight, or obese, and the disorder is more gender equitable compared to other eating disorders. Binge eating disorder is often triggered by stress and negative emotions and has high comorbidity with depression, anxiety, bipolar disorder, and substance use. Clinically, the distinction is critical. Bulimia carries higher acute medical risk due to purging behaviors, while binge eating disorder is more strongly associated with chronic metabolic and psychiatric comorbidity. Your role is to identify the pattern, assess medical and psychiatric risk, and match the level of care and intervention accordingly. This slide covers 3 feeding disorders that are often missed because they do not involve body image disturbance, so your assessment must focus on behavior, development, and medical risk rather than weight or shape concerns. Starting with pica, this involves persistent ingestion of non-nutritive substances such as dirt, ice, paper, or paint for at least 1 month, and it must not be developmentally appropriate, so not in children under age 2 or culturally sanctioned. It can occur in normally developing children, but is more common in individuals with intellectual disabilities. Clinically, pica is often identified after a medical complication, such as iron deficiency anemia, lead toxicity, or gastrointestinal issues, so a medical evaluation is essential. Treatment is primarily behavioral, with strong outcomes using reinforcement strategies, and caregiver involvement is critical. Rumination disorder involves repeated regurgitation of food that is rechewed, reswallowed, or spit out, occurring for at least 1 month and not due to a medical condition. A key distinction is that the behavior is often self-soothing rather than distress-driven, and patients may restrict eating in social situations to avoid embarrassment, which can lead to weight loss or malnutrition. It occurs across the lifespan but is more common in infants and individuals with developmental conditions. In infants, onset is typically between 3 and 12 months and can lead to failure to thrive. First-line treatment is diaphragmatic breathing, which helps interrupt the regurgitation cycle. Avoidant restrictive food intake disorder involves restrictive eating due to lack of interest in food, sensory sensitivities, or fear of adverse consequences like choking or vomiting, and there is no body image disturbance, which differentiates it from anorexia and bulimia. It often begins in childhood, has an equal sex distribution, and is commonly seen in patients with anxiety or autism spectrum disorder. Relational dynamics, including parental anxiety and feeding interactions, often play a role. The key takeaway is that these disorders require a different clinical lens. No body image component, strong behavioral and developmental factors, significant medical considerations, and essential involvement of caregivers or family in treatment. Now let's shift into the relational and cultural dimensions of eating disorders, focusing on how family systems and social context influence both development and treatment. Relational features vary across feeding and eating disorders, and understanding these patterns helps guide both assessment and intervention. In PICA, risk is often associated with environmental factors such as neglect, inadequate supervision, or developmental challenges, and caregiver involvement is essential for both safety and behavioral intervention. In rumination disorder, early caregiver-infant interactions and relational stress can play a role, with the behavior sometimes serving a self-soothing function and leading to social withdrawal over time. In avoidant restrictive food intake disorder, family dynamics are highly relevant. Parental anxiety, feeding patterns, and accommodation behaviors can reinforce restriction, and clinicians should assess how mealtime interactions are structured and experienced. In anorexia nervosa, families are often the primary source of collateral information due to limited patient insight, and systemic factors such as control, communication patterns, and cultural expectations around achievement and body image may influence presentation. In bulimia nervosa, there is often greater secrecy, shame, and potential associations with trauma, which can strain relationships and complicate disclosure. In binge eating disorder, patterns may include emotional coping within the family system and shared behavioral or environmental influences. Eating disorders do not occur equally across populations, and one of the biggest clinical mistakes is assuming they primarily affect young, thin, white females. In reality, eating disorders occur across all racial, ethnic, gender, and socioeconomic groups, but they are often underdiagnosed and undertreated in marginalized populations. For example, individuals from Black and Hispanic communities are less likely to be diagnosed and referred for treatment, even when symptoms are present, often due to provider bias and differences in how symptoms are expressed or reported. Socioeconomic status plays a major role. Patients with limited resources may experience food insecurity, inconsistent access to meals, or environments that do not support structured eating, which can complicate both diagnosis and treatment. In these cases, disordered eating behaviors may be driven by structural constraints rather than psychopathology alone, so your interventions must be realistic and context-specific. Gender considerations are also critical. While anorexia and bulimia are more commonly diagnosed in females, males are significantly underdiagnosed, often presenting with a focus on muscularity rather than thinness. Also, stigma may prevent men from seeking care. You must assess without bias and ask questions that capture different body ideals and behaviors. Cultural beliefs also influence how patients understand food, body image, and help seeking. In some cultures, discussing mental health or eating behaviors may carry stigma, and in others, body size ideals differ significantly from Western norms. This means you need to ask about the cultural meaning of food, eating patterns, and body image, rather than assuming pathology. Experiences such as discrimination, chronic stress, and trauma contribute to disordered eating through sustained physiologic and emotional dysregulation. Now let's shift into family systems assessment, focusing on how we evaluate eating disorders within the context of relationships, family dynamics, and the broader system influencing the patient's behavior. Assessment of eating disorders should follow a structured, stepwise framework that integrates medical, psychological, and relational domains. First, begin with a medical evaluation. This is not optional, because you must rule out underlying conditions and assess for complications of malnutrition or purging, including bradycardia, hypotension, electrolyte abnormalities, dehydration, or rapid weight loss, all of which can be life-threatening and require immediate referral or a higher level of care. Second, conduct a clinical interview that goes beyond symptoms and focuses on patterns such as restriction, binging, purging, exercise, and use of substances or medications for weight control, while also including family or collateral input, especially in anorexia where insight is often limited. Third, use formal tools to support assessment and track severity over time, but rely on clinical judgment to interpret the full picture and complete a mental health evaluation screening for depression, anxiety, trauma, substance use, and always assess suicide risk at every encounter. From a scope of practice perspective, there are critical cautions. PMHNPs and FNPs should not manage eating disorders in isolation when medical instability is present and must recognize when to escalate care, including cases of significant weight loss, unstable vital signs, electrolyte imbalance, active purging with complications, or inability to maintain nutrition, as these patients require multidisciplinary management. When assessing feeding and eating disorders, use a structured sequence of tools that moves from individual symptoms to personality and then to the family system. Start with the child eating disorder examination, a clinician-administered interview that evaluates eating behaviors and cognitions in children and adolescents, including restraint, eating concern, and body image. Clinical Pearl. This is especially useful when the history is unclear or the child minimizes symptoms because it provides a structured, objective assessment. Next, the Eating Disorder Inventory 1, EDI-1, assesses core psychological features such as drive for thinness, body dissatisfaction, and perfectionism. High perfectionism scores often predict rigidity and resistance in treatment. The Temperament and Character Inventory helps identify personality traits like harm avoidance, rigidity, or impulsivity. High harm avoidance is common in anorexia, while impulsivity is more often seen in binge-purge presentations. From a systems perspective, the family questionnaire evaluates dynamics such as criticism and emotional over-involvement. High emotional over-involvement can look supportive but may actually maintain the disorder. The Accommodations and Enabling Scale for Eating Disorders assesses how family members may unintentionally reinforce behaviors. Accommodation is one of the biggest barriers to recovery, especially in adolescence. Finally, the Eating Disorder Symptom Impact Scale measures functional impairment across emotional, social, and role domains. Assessment helps you justify level of care decisions and track meaningful improvement beyond weight alone. The takeaway is that these tools give you a layered understanding: symptoms, personality, family dynamics, and functional impact. Now let's shift into family systems interventions, focusing on how we actively engage families and relationships as part of treatment rather than treating the individual in isolation. Treatment for eating disorders occurs along a continuum of care, and one of your most important clinical responsibilities is determining the appropriate level of care based on medical risk, psychiatric severity, and functional impairment. At the lowest level, outpatient care is appropriate for medically stable patients who can maintain nutrition and engage in therapy, typically involving psychotherapy, medical monitoring, and nutrition support. If symptoms are more severe or outpatient treatment has failed, patients may require an intensive outpatient program, IOP, or partial hospitalization program, PHP, where they receive structured meals, therapy, and monitoring several hours per day. As risk increases, residential treatment provides 24-hour supervision in a non-hospital setting, often for patients who cannot maintain weight or safety independently. At the highest level, inpatient hospitalization is required for medical instability, such as severe malnutrition, electrolyte imbalance, bradycardia, or acute psychiatric risk, including suicidality. From a PMHNP and FNP perspective, the key is knowing when a patient is no longer safe to manage in outpatient care, if they cannot maintain nutrition, have unstable vital signs, or are at risk medically or psychiatrically. You must escalate care immediately. The takeaway is that eating disorder treatment is not one size fits all. It is dynamic, risk-based, and requires ongoing reassessment to match the patient to the safest and most effective level of care. Family-based therapy, or the Maudsley approach, is one of the most evidence-based treatments for adolescents with anorexia nervosa and positions the family as the primary agent of recovery, not the cause of the disorder. It progresses through 3 phases. In phase 1, parents take full control of nutrition and weight restoration. Do not negotiate with a malnourished brain. Nourishment comes first. In phase 2, control is gradually returned to the adolescent as eating stabilizes. And in phase 3, the focus shifts to normal development and relapse prevention. A key strategy throughout is externalizing the illness, which reduces blame and strengthens family cohesion. In addition to family-based therapy, multifamily therapy for anorexia nervosa brings multiple families together in a structured therapeutic setting, allowing them to learn from each other, reduce isolation, and build shared problem-solving skills. Families often respond more to each other than to the therapist, which makes this model particularly powerful in more severe or treatment-resistant cases. Both approaches emphasize that recovery is not an individual process but a systemic one, where engaging and empowering the family significantly improves outcomes. Caregiver support and couples therapy are essential in eating disorder treatment because these illnesses place a significant emotional and practical burden on loved ones, often leading to stress, anxiety, and burnout that can unintentionally affect care. Supporting caregivers through psychoeducation, coaching, and guidance helps them reduce accommodation behaviors, set appropriate boundaries, and respond consistently. A dysregulated caregiver cannot support a regulated recovery process. For adult patients, couples therapy focuses on improving communication, reducing secrecy and shame, and helping partners support recovery without becoming controlling or overly involved. Unlike parents in family-based therapy, partners support the process but do not take over it. The key takeaway is that engaging and stabilizing the support system improves treatment adherence, reduces relapse risk, and strengthens long-term recovery. Now let's shift into the ethical and legal implications of eating disorder treatment, focusing on the complex decisions clinicians must make to balance patient autonomy, safety, and professional responsibility. Ethical and legal considerations in eating disorder treatment center on competency, non-maleficence, confidentiality, minor consent, duty to protect, and safety planning, all of which arise frequently in practice. From a competency standpoint, you must practice within your scope and seek consultation or refer when cases become medically or psychiatrically complex. Lack of competence is a common source of harm. Non-maleficence is critical because eating disorders carry high mortality, meaning failure to intervene can result in serious harm. Confidentiality becomes more complex in family-based care, as you can only guarantee your own confidentiality, not that of other family members, so expectations must be clearly defined. With minors, parents or guardians typically provide consent, but you must still assess the minor's assent and capacity, particularly when resistance is present, and parental disagreement may require escalation if safety is compromised. The duty to protect becomes essential when a patient is at risk of serious harm, such as severe malnutrition, suicidality, or inability to maintain nutrition, and may require breaking confidentiality, involving caregivers, or initiating involuntary treatment to ensure safety. Safety planning should be ongoing and include assessment of medical stability, supervision needs, and escalation to higher levels of care when indicated, with the overall goal of balancing autonomy, legal authority, and patient safety. Jamie is a 14-year-old Black female with a complex chronic history of feeding and eating difficulties beginning at 10 months of age, with escalating severity over time, including 4 inpatient admissions at ages 10, 11, 12, and 13, followed by 2 years of ongoing outpatient treatment. She currently presents with restrictive eating and fluid intake, resulting in an approximate 5-pound weight loss, with contributing medical factors including jaw and bite problems, orthodontia, and a history of speech therapy related to dental and pronunciation issues. Her psychiatric and developmental history is notable for ADHD, currently managed on Strattera 80 milligrams with improved focus and honor roll performance. Possible autism spectrum disorder, rule out, mild dyspraxia, and asthma managed with PRN Ventolin, along with a significant family history of neurodevelopmental conditions, including her father and 2 siblings diagnosed with higher functioning autism. Socially and environmentally, her mother is the primary caregiver, while her father travels frequently and she spends hours on social media, particularly engaging with racial justice content on platforms like Discord, which has been identified as a stressor contributing to eating behaviors. Based on Jamie's presentation, the working diagnosis is avoidant restrictive food intake disorder, with anorexia nervosa restricting type ruled out. And the key distinction here is the absence of fear of weight gain or body image disturbance. Jamie is able to enjoy preferred foods and does not demonstrate the cognitive features typical of anorexia. Instead, her restriction appears to be driven by a combination of sensory, developmental, and medical factors, including long-standing feeding difficulties, jaw and orthodontic issues, and possible neurodevelopmental contributions such as ADHD, dyspraxia, and rule-out autism spectrum disorder. Her course is chronic, beginning in infancy and requiring multiple inpatient admissions, which supports a feeding disorder trajectory rather than a classic eating disorder driven by weight or shape concerns. This case discussion focuses on 4 key clinical questions. Question 1 asks, is this avoidant restrictive food intake disorder or anorexia nervosa? The correct diagnosis is avoidant restrictive food intake disorder, supported by the absence of fear of weight gain, which rules out criterion B for anorexia, the presence of sensory and physical barriers to eating, and no body image disturbance, ruling out criterion C. Question 2 asks, how should racial stress be addressed as a clinical target? This requires a culturally responsive approach using frameworks such as the LEARN model, listen, explain, acknowledge, recommend, negotiate, and the DSM-5 cultural formulation interview, which helps assess cultural identity, stressors, and supports, while applying trauma-informed care to address the impact of racism without pathologizing Jamie's response. Question 3 asks, how do we assess and address caregiver burden? Look at tools like the Accommodation and Enabling Scale for Eating Disorders and the Eating Disorder Symptom Impact Scale to evaluate family accommodation and caregiver strain, with interventions including psychoeducation for the mother, referral for her own medical care, family therapy to reduce mealtime stress, and reframing the mother as a co-patient in the system. Question 4 asks, how do we manage ballet as both a motivator and a risk factor for Jamie? Identify risks such as the emphasis on thinness and physical demands, and develop a relapse prevention plan that includes a minimum weight threshold for participation, coordinated communication with the dance instructor using appropriate releases, and a clear protocol or set of rules if weight declines. This slide highlights 5 critical takeaways that should guide your clinical practice with eating disorders. First, the family is the patient. This is the foundation of everything we've discussed. Families are not the cause of eating disorders. They are a primary part of the treatment, so they must be engaged early and consistently from the first session. Second, family-based therapy is the gold standard, particularly for adolescents with anorexia nervosa, where evidence shows it outperforms individual therapy within the first 3 years of illness. You must understand the 3 phases and recognize that models like the new Maudsley approach extend family involvement into adult care. Third, discrimination is a clinical risk factor. You should be actively screening for experiences of racism, classism, and other systemic stressors because these directly impact mental health and eating behaviors. Fourth, eating disorders can be fatal, which means you must act with urgency. Understand your state's involuntary treatment laws, recognize when a patient is no longer safe for outpatient care, and coordinate closely with medical providers across all levels of care. Finally, both culture and biology shape presentation, so remember to use tools like the cultural formulation interview while also considering genetics, developmental history, trauma, and cultural context. As we close, these references reflect the evidence base guiding today's discussion, including DSM-5 diagnostic criteria, family systems frameworks, and evidence-based interventions such as family-based therapy and culturally responsive assessment tools. As you move forward in practice, ask questions that uncover meaning, not just symptoms. Engage the family system, not just the individual, and always act with both clinical precision and compassion, because how you show up in these cases can change the trajectory of a life.